Good morning, good afternoon, and good evening, everyone. On behalf of the Transplantation Society and the Transplant Infectious Disease section, I would like to welcome you to today's webinar, Case-Based Approach to Fungal Infections in Transplant Patients, Management Across Regions. My name is Wanessa Clemente, and I'm a professor of medicine at the Federal University of Minas Gerais in Brazil, and the current president of the TID section. I am delighted to be joining you for this important education section planned by Dr. John Baddley and myself. The aim of this webinar is to provide guidance to clinicians responsible for the care of SOT donors, candidates, and recipients, focusing on key issues related to fungal infections. Thanks to all of you who are taking the time to participate from around the world. Before we begin, a few housekeeping items. This webinar is being recorded and will be made available following the section. Participants are encouraged to submit questions throughout the webinar using the Q&A function. We will reserve time at the end of the presentations for discussion and audience questions. As a warm-up, I will share with you some slides regarding what we will cover. So why fungal infections matter? Despite the low frequency, there's a high consequence. Outsized morbidity and mortality, with a mortality up to 70% of cases, depending on the pathogen and the organ type. Delayed diagnosis is not uncommon. Treatment might be complex with toxicity, drug interactions, and resistant patterns. Epidemiology is changing with the emergence of resistant pathogens and climate shifts. Limited access directly affects the outcome. In diagnostics, and antifungal drugs are not equally available worldwide. Invasive fungal diseases are recognized as a neglected global health threat. But the risk is dynamic: timeline, organ type, and immunosuppression. The question is not only which fungus, but when and whom and where. In daily practice, risk assessment is complicated, and we should always combine the timing, the organ type, the type of immunosuppression, complications, and geography. And what we will discuss today? We prepared this presentation to discuss about the organisms and syndromes that best illustrate the key challenges in transplant mycology. A practical selection: what kills most, what is emerging, what is often missed. So we are going to discuss about pulmonary aspergillosis, mucormycosis, yeast infections, cryptococcosis, and this will be a case-based approach. Together, these cases will address when to suspect, how to diagnose, when to escalate, and when surgery matters. Are the central determinants for survival, graft outcomes, and equality in transplant care depend on the diagnosis and treatment access. If we cannot treat early, we cannot treat early if we cannot diagnose early. Cultures can be slow and often insensitive. Diagnostic tools are not always available. Antifungal access is unequal. Toxicity and drug interactions can occur. And we should not forget about donor-derived fungal infections, because the pathogens can be transmitted through the transplanted organ and involved the graft, the donor vessels, the preservation fluid, and the anastomotic site. Clinical infections are often early, abrupt, and non-specific, and they require urgent recognition, rapid communication between transplant teams, and immediate antifungal management. The imputability of the donor-derived fungal infection is also an often challenge. And fungal infections require systems and not only individual expertise. We have to take into account the local epidemiology, stratified prophylaxis, have a rapid diagnostic pathways, consider antifungal stewardship. It depends on multidisciplinary review and DDI alert systems. So thank you for being here. And now let us hear for our expert panel. Dr. Husain from Canada that will present pulmonary aspergillosis. Dr. Monica Slavin from Australia, mucormycosis, Dr. Emily Eichenberger from USA, and Dr. John Baddley from USA as well. They will present the concepts of daily practice, how to recognize the red flags, how to use the diagnostic tools, and how to select therapy and act early to change the outcomes. So our first speaker today is Dr. Shahid Husain. Dr. Husain is a professor of medicine at the University of Toronto and the medical director of the Antimicrobial Stewardship Program within the University Health Network. He is internationally recognized for his contributions to transplant infectious diseases and has played leading roles in developing guidelines related to fungal infections and management in transplant patients. Please join me in welcome Dr. Husain.
Thank you, Wanessa, for the kind introduction. And I would like to thank the organizers, especially from TTS and TID, for inviting me to do this presentation. So I'll start with the case as suggested. So this is a patient that we saw a few years ago. Is a 33-year-old female with underlying cystic fibrosis and had undergone a bilateral lung transplant. She was noted to have colonization with Aspergillus fumigatus in the sputum 6 months ago, but the recent disputati were all negative. She had uncomplicated surgery and discharged home on day 12. As a part of the screening, we do perform bronchoscopy at regular intervals, which is 4 weeks, 3 months, 6 months, 9 months, and 12 months during the first year. So she came in for surveillance bronchoscopy at 4 weeks after transplant. And when the bronchoscopy was performed, you can see the bronchologist saw the dusky appearing tracheal area with some protrusion of the material. And here you can, in the second picture on the bottom, you can identify the stitches. So it is not only bronchial anastomotic infection, but it is also extending below the bronchial anastomosis. And this X-ray that was done before the bronchoscopy was essentially normal. So the point that I'm trying here to make is that this is a clinical syndrome which is rather unique to lung transplant recipients, where your X-ray might be normal, but when you do the bronchoscopy, you will be able to identify the lesions in the airways. When you look at the clinical presentation of invasive aspergillosis in solid organ transplants, this is around about 3.6% are tracheobronchitis. Most disseminated, most of the infections are invasive pulmonary aspergillosis, involving the lungs, and very occasionally you will see CNS infection in the current era. That is probably because of the early recognitions and the surveillance of the transplant recipients. One of the unique clinical syndrome in lung transplant recipients, as is evident by this case, is colonization. What is colonization? Colonization is the presence of fungus in the respiratory secretions, sputum or BAL, either detected by culture, PCR, or biomarker. But the key thing is it is in the absence of symptoms, radiologic, and endobronchial changes. The reason to recognize colonization as the important risk factors is that the colonization may predispose to invasive pulmonary aspergillosis, especially in the setting of lung transplant recipients. However, there are some data to suggest that pre-transplant colonization liver transplant recipients may also predispose to invasive aspergillosis. If you have cystic fibrosis, then you probably get tracheobronchitis, which is the case in 1/4 of the patients who are colonized. And if you're non-cystic fibrosis patient, around about 1/4 of these patients will go on to develop invasive pulmonary aspergillosis. When you look at the radial presentation, a couple of things that needs to be recognized is that halo sign, which you are used to in hematopoietic stem cell transplant recipients, are rarely seen. It's mostly ground glass opacities and consolidations that happens as compared to hematological malignancies, where you see the macronodules and halo signs. In terms of the timeline, this fits in the timeline as been highlighted here. This is from the Swiss cohort study that was published in 2020. If you will concentrate on the bottom, you will see the Aspergillus species tend to happen early up till 6 months, then there's a hiatus, and then happen late. This is due to the anastomotic complications. But typically, tracheobronchitis does happen before the maturation of the disease, maturation of the anastomosis, that is up till 6 weeks. When you look at the distribution of IFI among the solid organ transplant, this is from the Pathline, slightly older data, but the recent cohort also follow the same pattern. Lung transplant patients are unique in a sense that they have highest incidence of invasive aspergillosis as compared to other solid organ transplant recipients. Now, what are the risk factors of invasive aspergillosis in lung transplant? On the left is the risk factors which are relatively unique to lung transplant recipients, and on the right are the surgical risk factors that can happen. So lung transplant, as you know, is only one of the organs that is in continuous contact with pathogens, higher state of immunization. If you want to remember one risk factor, it will be airways colonization, presence of pulmonary stent, native lung, hypogammaglobulinemia, and community-acquired respiratory virus infection. While statin use in a couple of studies has known to be protective. However, as a result of surgery, there's denervation, lymphatic disruptions, impaired cough reflexes, and decreased mucociliary clearance that can predispose to further infections. The risk factors of invasive aspergillosis, as it is not very common, the solid organ transplants have been studied, particularly in heart transplant and liver transplants. And here also, Aspergillus colonization in heart transplant is a significant risk factors. Airborne Aspergillus spores in ICU, thoracic reoperation or post-transplant hemodialysis are the other two. Other important one in risk factors for IA in kidney transplant, it is a history of COPD, acute rejection lasting months, graft failure, and prolonged duration of steroids. In livers, retransplantation renal failure, permanent hepatic failure, MEL of greater than 30, reoperation involving thoracic abdominal cavity, and recently systemic antibiotic use have been implicated to portend high risk of invasive aspergillosis. I'm not going to go in detail of this slide, which I would strongly recommend to review once you get, but some teaching points that GM or galactomannan has lower sensitivity in solid organ transplants as compared to other immunocompromised patient populations. And the data shows that serum GM is not useful for monitoring and diagnosing invasive aspergillosis in solid organ transplant. Um, there have been case reports of cell-free DNA for the diagnosis in solid organ transplant, but a larger study with the solid organ transplant cohort is lacking. Interestingly, PCR and metagenomic next generation sequencing has almost similar diagnostic characteristics as in solid organ transplant as compared to hematological malignancies. The treatment of invasive aspergillosis has not been specifically studied in solid organ transplant recipient, but it follows the same paradigm which is being applied in hematological malignancies. And this slide is showing the 4 randomized controlled trials that has been done for the treatment of invasive aspergillosis. The voriconazole still remains the drug of choice, followed by isavuconazole and posaconazole. There are several guidelines, so I've included this slide just for the sake of completion, but keep watching. There are new guidelines about to come out for invasive aspergillosis from IDSA this summer and from ECMM in this fall that are going to review the existing data and make some new recommendations. But the bottom line is both universal and preemptive therapy has been recommended in lung transplant recipients. In livers, it is only targeted therapy. You cannot use preemptive therapy because in early liver transplant, the galactomannan can be false. Serum galactomannan can be falsely positive. You've heard about all the new drugs. The data of all the new drugs in solid organ transplant recipients are lacking. There have been a study of oral inhaled antibiotics, antifungals, oproconazole that was terminated early, but these are studied in combination. The new drug that is a standalone neuroantifungal for the treatment is fosfomanogepix that is being studied. I think this is the most important slide for the approach of invasive aspergillosis in solid organ. First of all, act early. Diagnostic certainty often lags behind disease progression. In solid organ transplant recipients, suspect IA when there's a compatible clinical syndrome plus SOT risk factors. So the approach that I take is define the risk, diagnose fast, and treat early. And if you can control host in terms of immunosuppression or looking at other risk factors that may predispose, such as CMV infection, and then reassess with CT at specific intervals. Specific decision points that you have to be cognizant of is lung transplant phenotypes such as colonization and tracheobronchitis. Most of the centers use surveillance bronchoscopy, but you should have low threshold for bronchoscopy and treatment. Azoles are the drug of choice, but these patients are on calcineurin inhibitors, so you have to be careful about the interactions. The other things that we see is the QTc prolongation. So for voriconazole especially, the TDMs are highly recommended. One thing that we are seeing in the advent of universal prophylaxis is breakthrough IA among the patients who are receiving universal prophylaxis, and the incidence ranges from 3 to 6%. So you should confirm exposure or adherence, obtain a species, and especially the susceptibility, and consider azole resistance for non-fumigatus species. So with that, I'll thank you for listening. This was a whirlwind tour of the invasive pulmonary aspergillosis in solid organ transplants. But no talk will be complete without highlighting the fact that we need to be good stewards of antifungals in these patient population, but because they need it frequently, and they need it they need more as compared to other type of transplants. So this is a very nice paper that was done, which deals with the core recommendation for antifungal stewardship. With that, I'll thank you and happy to take any questions.
So thank you very much, Dr. Husain, for that excellent presentation. Our next speaker is Dr. Monica Slavin from Australia. Professor Slavin is the director of the Department of Infectious Disease at Peter MacCallum Cancer Center in Melbourne, and serves as the chair of infections in cancer and transplantation at the University of Melbourne. She is internationally recognized for her work in infections among immunocompromised patients, particularly invasive fungal infections. Please welcome Dr. Slavin.
Thank you so much, Wanessa, for that nice introduction. And now I'm going to talk about mucormycosis. So these are my disclosures. Moving on. And next slide, please. So this is a clinical case of a 51-year-old male. I'm going to change slightly to the stem cell transplant setting here with acute leukemia, receiving hyperfractionated CVAD. And because of this chemotherapy with the vincristine, azoles were contraindicated, and so he was receiving intermittent ambisome prophylaxis. He developed febrile neutropenia, which was prolonged and didn't settle with broad-spectrum antibiotics, and so went on to CT scan of the chest. And as suspected, this patient had invasive or nodules suggestive of invasive fungal infection in the chest. So there were new pulmonary nodules. He'd had a PET scan prior to treatment, which didn't show any nodules, but now he had nodules in the right upper lobe, right lower lobe, and left lower lobe, as you can see here. Next slide. So he went to have a biopsy of the right upper lobe nodule, and you can see the histopathology here. It was really suggestive of invasive mucormycosis. As usual, or as often is the case, the cultures did not grow, and so the specimen from his lung was sent for panfungal PCR, which detected rhizomucor. He started on liposomal amphotericin B at 5 milligrams per kilogram per day. And there was a discussion about whether this patient could go to surgery, because we always consider surgery alongside of mucor. But because he was in the early stages of treatment for his malignancy, and because he had multiple lesions spread throughout 3 lobes of the lung, it was thought not feasible at that point to undergo surgery. And he continued with liposomal amphotericin B and close monitoring. He went for a review with a PET CT at 2 weeks into treatment, because we wanted to monitor very closely his response, and we know that mucor can progress quite rapidly. What was seen there was worsening of the nodules in his lung, and I'm showing you one here, which is much larger with much more ground glass around it. So under discussion, he went for a VATS wedge resection of the right upper and left lower lobe nodules. Unfortunately, the right lower lobe nodule was not resectable. Next slide. So what do we find? Well, we confirmed that it was mucormycosis on histology, but what was very interesting was that the right upper lobe nodule also grew Scedosporium apiospermum, which we know to be a fungus resistant to amphotericin B, and likely the reason for the progression at 2 weeks of treatment of amphotericin. So voriconazole and terbinafine was added, and he underwent several more cycles of hypercvad and also successfully went to his planned allogeneic stem cell transplant 30 weeks later with posaconazole prophylaxis and no reactivation of his mucor or Scedosporium infection. Next slide. So this leads me to talk about breakthrough mold infections in hematology patients. And although invasive aspergillosis is still the most common cause, we do see now mucorales and other invasive mold infections as per this patient in those receiving prophylaxis. And what we generally would consider is the prophylaxis that they've received, the local epidemiology and the prevalence of azole-resistant or other resistant mold infections, and particularly the stage of cancer and treatment, because we know that aspergillus plus an additional fungal infection is more commonly seen in those that are heavily immunosuppressed. So interesting that our case was very early in the course of his chemotherapy, actually undergoing his first cycle. But the piece of epidemiology I didn't tell you was that he was originally from Africa, and he'd recently visited Africa just prior to being diagnosed with his acute leukemia. And although mucorales are not very common infections straight up in first line of therapy in Australia, I think it may be a more common infection to acquire in Africa. So next slide, please. So mixed invasive mold infections, how often do we see them? Well, we reviewed our experience in the allo transplant setting and found that about 10% of patients receiving mold active prophylaxis with posaconazole did develop mixed mold infections. Most of these patients had advanced graft versus host disease or relapsed progressive malignancy, and all of these were breakthrough molds. And you could see here what were responsible for these mixed molds, commonly aspergillus, but also a mucor and Scedosporium or lamentaspora. And a European study also looked at the prevalence of mucorales in patients who were diagnosed with invasive aspergillosis. And in the single centre, detecting a positive mucorales PCR in blood occurred in about 8% of patients diagnosed with invasive aspergillosis. And in a European multi-centre study, those that had proven or probable invasive aspergillosis, 29% were also positive for mucorales DNA, including 11 not seen by routine diagnostics. And of course, those that were defined as possible IMR, invasive mold infection, about 25% had mucorales. So you can see, although this may have been a slightly biased sample, that it's not uncommon finding to detect mucorales in patients with invasive aspergillosis. Next slide, please. Well, how do we diagnose it? And the standby has always been histopathology. As I've mentioned, the tissue can be damaged on taking a biopsy, and often cultures do not grow. So taking the global guidelines on mucorales, what are the key points that come out about diagnosis? Now, these guidelines were published in 2019, but they do say this is an emergency, rapid action is required. The patient should undergo imaging and staging, sampling, staining with special stains or hyphal brighteners to detect the hyphae. And of course, that grinding or damage can lead to low yield of the cultures. They recommend in 2019 that molecular diagnosis on tissue was moderately recommended, but we'll see that things have changed since then, and I think this molecular diagnosis has become a lot more common. Next slide, please. The other way, of course, that we rely on is looking at radiology, and there are some clues in radiology. This arrow here shows us the reverse halo sign. We can also see the cutoff sign on angiography, where the big vessel feeding this invasive infection is blocked by clot and infection, and we can see rapid progression. And on this last one, we can see invasion across tissue planes, and all of these are very characteristic of mucorales. Next slide, please. However, the mucorales PCR has become much more widely used in Europe and in some centres in the US as well. And this recent systematic review and meta-analysis of studies, about 30 studies looking at mucorales PCR, did show that it performed very well in diagnosing mucormycosis, particularly in blood, BAL fluid, and tissue. Best sample was BAL fluid, but blood and tissue were close behind. And this group made a case for including it into definitions now of invasive mucormycosis, invasive fungal infections. And these definitions are due to be updated by MSG and ECMM later this year. So it'll be interesting to see if this is the case. Next slide. Looking a little bit more closely at the mucorales PCR, it's been widely used in French university hospitals. Many have used it for some time. They do say that the commercial kits are equally as good as in-house tests, and the major factor in the sensitivity of the test is the pre-analytical variables such as DNA extraction and volume. So this is what really underpins sensitivity of the test. And implementation in at least one centre has been shown to improve the outcomes of haematology patients by diagnosing mucorales earlier from blood samples. Next slide. Well, others have also looked at DNA for diagnosing mucorales, and there are multiple studies out there in the literature. All of these ones that I'm presenting on this slide come from US centres, and the two approaches has been to use either a quantitative targeted PCR or to use whole genome sequencing. And the last two studies, reference 4 and 5, have used the whole genome sequencing approach. And actually, these studies are not purely restricted to mucorales. They look at Aspergillus, mucorales, Fusarium, and Scedosporium diagnosis. But they do detect that you can find mucorales in blood up to 3 weeks before clinical symptoms, and that mucorales, the test with whole genome sequencing was highly sensitive on plasma. So these are small studies, retrospective case control studies. So they still require validation, but I think this is very interesting that multiple sites are finding these useful tests of mucorales DNA detection in blood. Next slide. What about the new antifungals, and what do they offer for treatment of mucorales? Well, I think olorifim is not recognised to have any activity for mucorales. Fosmanogepix is still really under evaluation. There is some experience using it as salvage, but not very much, and not much has been published. And abrexafungerp, there are only animal studies using it in combination with liposomal amphotericin B. So not a lot happening with these newer antifungals until we get to the newer modifications of amphotericin B. And there I think we might find some use. With the lipid nanocrystal amphotericin B, obviously that can be given orally and could be quite a good option for mucorales treatment. However, studies have really stagnated, and there are no studies looking at this at the moment. The EL219, the terlitricin, the new modification of amphotericin B, is required to be given IV, but is renal sparing. So again, may find a role in this disease. Next slide, please. So in conclusion, I think that we've had a very quick overview of Mucorales infections in hematology patients. They may be part of a mixed infection, may be part of a breakthrough infection. That's often where we see them in our patients, especially in those with advanced or underlying disease. The prevalence very much depends on the local epidemiology, the type of prophylaxis that's been used, and the individual patient risks. Usually in hematology, we see this disease in the lungs or in the sinus, and I've shown you a case in the lungs. It is a medical emergency requiring rapid diagnosis, prompt antifungal therapy, and consideration of surgery, recognising that surgery is not always possible. New diagnostics are promising, particularly PCR on blood and respiratory samples, and also the cell-free DNA whole genome sequencing on blood or plasma. The newer antifungals may have a role, but they're still really being evaluated at this time. So I'll finish there and thank you for your attention.
Thank you, Dr. Slavin, for that insightful presentation. It's now my pleasure to introduce our third speaker, Dr. Emily Eichenberger from the US. Dr. Eichenberger is Assistant Professor of Medicine of the Division of Infectious Disease at the Emory University School of Medicine. Her research focuses on improving outcomes among SOT recipients, particularly those experiencing severe infections and fungal infections. Please join me in welcoming Dr. Eichenberger.
Thank you so much. So yes, I'll be talking mainly about Candida auris within solid organ transplant patients. So we'll start with a case of someone I took care of a couple months ago on the inpatient wards. This is a 72-year-old man with ischemic cardiomyopathy and obesity. He was admitted with cardiogenic shock, underwent right axillary impella placement on hospital day 1, and had a fairly uneventful hospital course until 45 days later, he received a heart transplant. Post-transplant was immediately complicated by encephalopathy, renal failure requiring continuous renal replacement therapy, and inability to protect his airway, requiring intubation and mechanical ventilation. Owing to his persistent encephalopathy, blood cultures were collected, which grew Candida auris. So let's talk about Candidazyma auris or Candida auris. This was first described in 2009 in Japan, and since that time has been identified in over 50 countries. It's responsible for many ICU outbreaks, healthcare outbreaks, and responsible for 30 to 60% mortality in Candida auris bloodstream infection. So it is intrinsically a very resistant yeast. Up to 90% of isolates are resistant to fluconazole, 8 to 35% are resistant to amphotericin B, and in North America, up to 5% are resistant to echinocandins. One of the key resistance concerns is that echinocandin resistance actually tripled in 2021 relative to the 2 years prior, and resistance to echinocandins can develop on therapy at these particular hotspot mutations, FKS1 and FKS2. So how do we treat Candida auris bloodstream infection? So this is a summary of the CDC and the ECMM, ISHAM, ASM guidelines, where they recommend that the initial treatment for Candida auris bloodstream infection is an echinocandin. In addition, it's really important to ensure that we're obtaining susceptibilities to understand whether we're using the appropriate therapy. Central venous catheters should be removed in the first 48 to 72 hours, as Candida auris, like all other Candida, can form potent biofilms on plastics and other foreign objects. Daily blood cultures are important to understand whether we are dealing with a persistent fungemia or whether we have eradicated it quickly. Transplant infectious disease should be involved in the care of these patients, and it's important to understand where the Candida came from and to obtain source control whenever and wherever possible. The guidelines don't recommend echocardiography for everyone right off the bat, but they do indicate that it's important to obtain an echo for those who have persistent fungemia, for those with risk factors for endocarditis, and for those who have any sort of physical exam features that are suggestive of metastatic infection or endocarditis. I have an asterisk here just to indicate that for those who have an echinocandin resistant strain, the guidelines indicate that amphotericin B is the alternative first-line agent. Duration of treatment, provided there's no metastatic infection or other sort of site of infection, is 14 days from clearance. I'm going to take a brief detour from the treatment algorithm just to think through some echinocandin dosing considerations, as this is something that frequently comes up when I'm on the wards. So the guidelines recommend standard dosing of echinocandins for Candida auris infections, and there's no randomized controlled trial to support pushing the dose higher in echinocandins for Candida auris. However, PK/PD modeling studies show that standard dosing of echinocandins may not be optimal at higher MICs or in critically ill patients or those with altered clearance. And so it may be reasonable to consider pushing your dose of your echinocandin in patients with altered volumes of distribution, such as patients with obesity, critical illness, hypoalbuminemia, patients with altered drug clearance, so those on continuous renal replacement therapy or on ECMO, and patients with an elevated MIC that's still susceptible, but it's starting to creep up to that limit. So those may be the situations in which you may want to push the dose. So coming back to our treatment algorithm, the guidelines indicate that persistent fungemia, so patients who have greater than 5 days of positive blood cultures on appropriate therapy, we may want to consider second-line treatment options. And the guidelines indicate that a switch to liposomal amphotericin B may be helpful. And note that the dose is actually 5 mg per kg per day and not 3 mg per kg per day. It's important to reevaluate for source of infection, metastatic foci of infection, so CT scans, PET scans, etc., to make sure we've caught all sort of hidden nidus of infection. Performing source control whenever and wherever possible. And if you haven't already, obtaining an echocardiogram is going to be important to really take a close look at those valves. If you've already obtained a transthoracic echocardiogram, even repeating one can be helpful to discern whether there's a change in the valves or if there's a development of a perivalvular abscess. Optho evaluation, this is heavily debated in the literature, and I won't get into the debate today, except for to say that the guidelines say that it's reasonable to obtain a fundoscopic exam in immunocompromised patients, i.e. our transplant patients, in patients who have persistent fungemia or those with ocular symptoms. In cases where candidemia is persistent beyond this point, and the guidelines don't give a specific cutoff, but if we're dealing with persistent fungemia, we may want to consider salvage therapy. So what does that look like? Again, we're coming back to this idea of controlling the source of infection. You want to check for evolving resistance if you have persistent fungemia beyond this point, because again, echinocandin resistance can evolve while on therapy. If you are dealing with an echinocandin resistant strain or even a pan-resistant strain, you may want to consider some of the novel agents like fosmanogepix or ibrexafungerp, and these can be obtained through expanded access programs, and I'll link to this. There's a link to this on the CDC website, which I'll provide a QR code at the end. And then lastly, if you're not dealing with one of these kind of echinocandin-resistant isolates, but you're having troubles clearing the infection, there has been something that has arisen in my practice, which is the question of combination therapy. So I'll take another detour just to talk about combination therapy. So this is not endorsed by the guidelines, except when you're talking about endocarditis. But the data for combination exist almost exclusively in vitro for Candida auris. There was only one report I could find in transplant patients where 2 out of 5 patients with Candida auris fungemia received combination therapy. And it's unclear if it actually moved the needle one way or the other in that study. Expert opinion, however, indicates that it may be reasonable for refractory cases. So as I mentioned, really all of the data for combination therapy is in vitro, and I've summarized it here in these colorful boxes. So some of the studies have looked at echinocandins with isavuconazole, echinocandins with amphotericin, and even echinocandins with flucytosine among echinocandin-resistant isolates. And synergy was demonstrated at high rates in all of these studies, and there was no evidence of any antagonism. So again, we need some human data really to help us understand what to do, but the in vitro data are promising. So moving away from kind of treatment and now thinking through some infection control considerations. So the reality is Candida auris colonizes patients rapidly. It colonizes the skin. You can detect it in the axilla, the groin, the nares, and it hides in hair follicles, which makes it difficult to surveil. Candidemia can occur in up to a quarter of critically ill patients colonized with Candida auris. That is a very significant risk factor for subsequent infection. So what do we do about this? So there's no reliable decolonization strategy, but the CDC guidelines indicate that daily CHG bathing can reduce shedding and therefore hopefully reduce transmission risk. It's important that we don't treat colonized patients who don't have evidence of infection. We want to make sure that we're stewards of our antifungal agents and save them for when we need them. Candida auris also readily contaminates the environment. It will contaminate shared medical equipment like blood pressure cuffs, thermometers, ultrasound probes, physical therapy equipment, etc. And it can persist on dry surfaces for weeks to months. It's been linked to prolonged ICU and transplant ward outbreaks. So it's important that we take patients who are colonized or infected with Candida auris and put them into contact precautions and give them their own dedicated patient equipment whenever we can, their own blood pressure cuffs, stethoscopes, etc. Making sure that we are disinfecting shared medical equipment like glucometers, etc., with these special EPA registered disinfectants. And there's a whole list on the CDC website of effective compounds against C. auris. Note that quaternary ammonia compounds are not effective. Using alcohol-based hand hygiene is a must. And then, of course, daily room cleaning is important, and enhanced terminal clean at discharge. Making sure those places that the patient has visited, CT scanner, PET scanner, ORs are also have that enhanced clean as well. I'm going to finish up in the last minute here, just thinking through some donor considerations in Candida auris. And I'm going to caveat this by saying that this is a data-free zone. So we know that Candida auris can be transmitted from donors to recipients. There have been articles in the literature documenting this. And in each of these cases, the donor had an infection with Candida auris that was discovered kind of later after the infection developed in the recipient. It's important, however, when we hear of a donor who has Candida auris to distinguish colonization from infection. And it's important to also note that there's no standardized Candida auris screening protocols for donors. Some hospitals perform routine screening for C. auris, some don't. And so there's no real standardization, but there's a really wonderful article that I've indicated at the bottom of the slide here by Ceballos and Mishkin et al. In Transplant Infectious Diseases that cover kind of the current knowledge and all of the gaps that we're facing with donor considerations in Candida auris. So what do we do if we hear that the donor has Candida auris? Well, really, we don't know. This is kind of be a case-by-case decision, ideally multidisciplinary with heavy involvement from transplant infectious disease to understand what is the risk of transmission and the risk of waitlist mortality. If you do decide to accept the organ, you may want to consider prophylactic echinocandins in the recipient. But again, we really don't know, and this is something that requires a lot more data to help us understand. So I'm just going to wrap up by leaving this kind of key resources slide up for a moment. Just if you ever need kind of quick at your fingertips help, the CDC guidelines, the ECMM, ISHAM, ASM global guidelines, very helpful. The CDC infection control guidance is also helpful with the list of compounds that are effective against C. auris. And then finally, this really nice review article talking about Candida auris screening and kind of donor management in organ transplant.
So thank you, Dr. Eichenberger, for this amazing presentation. Our final speaker today is Dr. John Baddley from the US. Dr. Baddley is a professor of medicine at the Johns Hopkins University School of Medicine and the past president of the TID section. He's global authority in TID and fungal infections with expertise in invasive mycosis, epidemiology, and infections in transplant recipients. His contributions have helped shape the contemporary practice and education in TID worldwide. He has a lead or participated in the majority of the guidelines related to cryptococcosis for many societies. Please welcome Dr. Baddley.
Thanks, Vanessa, for the kind introduction, and thanks to TID section and TTS for the invitation to participate in this webinar. So I'll start with a case today that I saw in the fall of 2005. The patient was a 74-year-old female who had a renal transplant in 2018. Other relevant past medical history She had been diagnosed with anal rectal cancer in 2024 and was receiving intermittent chemotherapy. So she went to her gynecology oncology clinic appointment in September 2025 for a routine visit. At that time, she complained of about a 2-week history of bad migraines and kind of malaise that was new over the past week or so. She did not have dysuria or other symptoms. She had some labs done, and then later that day, the urinalysis came back with abnormal 2+ leukocyte esterase and also 20 to 40 white blood cells seen. The gyn-onc team saw this and prescribed ciprofloxacin for the patient. Her immunosuppression at this time included tacrolimus, belatacept, and prednisone. So a week later, she was seen in the renal transplant clinic and complained of a change in her headache consistency. She had a few days of pressure headaches that were worse in the morning and that were different from her typical migraines. No fever, no chills or weight loss or eye issues, but she did notice some increased fatigue over the past week and now some new dizziness. During the visit, the renal transplant team reviewed her recent cultures and a urinalysis, and they saw that the urine had a positive culture for Cryptococcus neoformans 20,000 CFUs. Her creatinine was also 2.2, which was increased from a baseline of about 1.7. And so because of these issues, she was sent to direct admission to the hospital. She had a lumbar puncture. Opening pressure was 19, which is actually within the normal limits. White blood cell count was elevated at 44, 91% lymphocytes. Her CSF culture was negative, but the CSF cryptococcal antigen test was positive at a dilution of 1 to 10. So clearly this transplant patient has cryptococcosis, and cryptococcosis is an uncommon infection in general, but really it's the third most common fungal infection among patients who receive a solid organ transplant, as this table indicates. And perhaps it's a little more common among kidney patients than other different organ types. This is a large cohort study published a few years ago looking at patients with cryptococcosis that include all different types. And in this particular study, 129 patients with solid organ transplant were represented. And as you can see, again, among this group of patients, the patients with kidney transplant were more highly represented. So what does cryptococcosis do? Well, clearly it affects lots of different sites, but primarily the central nervous system site, the brain, the meninges, as our patient had. It can also involve the lung commonly, or the blood. Other sites, such as skin, bone, and joint, et cetera, are less common. And many of these cases, the patients with transplant at least have disseminated disease, as our patient did. And sure enough, our patient had asymptomatic funguria, and that's how this really was discovered. Again, in addition, she had several weeks of mental status changes and a little bit of dizziness and headaches that would also make us think about cryptococcosis. So how do we diagnose cryptococcosis? And this is a very busy slide, but in general, two main methods. Number one is culture. It's a very sensitive test, especially in the CSF. And again, our patient did not have a positive CSF culture, which does happen rarely. In addition, our patient had a positive urine culture. Other tissues, lung specimens, and blood also commonly positive in this situation. But probably the most common test we use, at least in the United States, is the cryptococcal antigen test. It's seen in the bottom right figure. It is a very easy and quick test and very sensitive and specific. In fact, probably more sensitive than the culture. So in patients with disseminated disease who have a CNS infection, the test sensitivity is greater than 95% and the specificity is 98%. And this test is fairly widely available around the world and quite easy to use. So how do we treat cryptococcal disease? And this is a recent guideline from ECMM, ISHM, and ASM. And typically, per the solid organ transplant AST guidelines, we require a minimum of 2 weeks of therapy. So here in the red box is SOT. Typically, we give a liposomal amphotericin B, 3 to 4 milligrams per kilogram daily. And in addition, flucytosine, 25 milligrams per kilogram 4 times a day. That is a typical thing we do. And then after the patient's better, we switch them to a consolidation, which is a dose of fluconazole, 400 to 800 milligrams a day for 8 weeks. And then finally over to fluconazole, 200 milligrams daily for about 12 months. So that's a typical solid organ transplant guideline recommendation based on this document as well. So one caveat is that availability of antifungal therapies is not perfect around the world and in all situations. These data are about 10 years old, but it just points out that amphotericin B and flucytosine are not always available and ready for the clinicians. And so this actually is amphotericin B traditional deoxycholate formulation, but in fact, the liposomal preparation is really even harder to get. And in 2016, really, 20% of countries did not have AmphoB available and 80% did not have flucytosine available. So although we say this is our go-to primary recommendation for treatment, again, you have to be aware of these limitations where you're practicing. And other issues with amphotericin B, as we all know, has a lot of side effects. And this is just a Cochrane meta-analysis from a few years ago comparing liposomal to amphotericin B to conventional amphotericin B. And here the outcome is twofold increase in baseline serum creatinine. So as you can see in this plot here, there's a better renal outcome with the use of liposomal amphotericin B. However, up to 15% of people who receive liposomal amphotericin B will have renal insufficiencies. So what about a different paradigm for the treatment of cryptococcosis? This was an interesting study that I'll just talk about quickly. This is using a high-dose liposomal amphotericin B preparation as one dose compared to standard of care. And again, and note that this was in patients living with HIV and in 5 African countries. Again, so not in solid organ transplant patients. And just briefly, the drug regimen that was experimented is on top, the single infusion instead of a daily infusion, followed by other standard therapies. And as you can see on the top right, the mortality at 10 weeks was non-inferior to the standard of care WHO regimen at the time. And then safety-wise, clearly this high dose amphotericin B compared to the standard WHO regimen in HIV patients was safer with regards to adverse effects, renal disease, and also anemia and hypokalemia. So very interesting to think about, would this paradigm fit with our solid organ transplant patients? And I think the future will determine that. So just some final considerations. Cryptococcosis is an uncommon infection, but important when really about 3% of solid organ patients, it's the third most common, fungal infection. Be aware of toxicity of amphotericin B and other drugs, and be aware of the limitations of getting some of these therapies around the world. We do see elevated intracranial pressure in patients with meningitis and solid organ transplant patients, but we didn't see it with this particular case. One thing we've also seen in a few percentage of people is immune response inflammatory syndrome, which can be devastating. So be aware of that if you reduce immune therapy at the time of diagnosis. And finally, antifungal resistance. There's not a whole lot in the solid organ transplant population, but certainly we're seeing some emerging resistance with fluconazole and cryptococcus. Thanks very much for your time.
Thank you, Dr. Baddley. I think that this is a very interesting collection of cases in SOT and stem cell. And all the 4 cases share the window of diagnostic opportunity. So now to the key Q&A section. We will move to this. And as a reminder, participants may contribute to submit questions in the box. We will do our best to address as many questions as time allows. And I have one question here from Martha Siles. In your opinion, is isovuconazole the drug of choice for prophylaxis in SOT patients with risk factor for invasive aspergillosis because it's reduced drug interaction profile? And is it also the preferred treatment for invasive aspergillosis? I think it's for you, Dr. Husain.
Thank you for the question. So I would start by saying this remains to be seen. There have been one study from the Pittsburgh group where they have used isavuconazole for universal prophylaxis in lung transplant, and if I remember correctly, the breakthrough infection rate was 4 to 5%. So clearly, isavuconazole provides some advantage in terms of less interaction and less QT intervals. But stay tuned for the new IDSA guidelines. Those will be coming out soon, and we'll have a wholesome discussion related to that. At this point, there is no drug that has been shown superior of one over other. And I think the patient situation or patient underlying conditions may determine the choice of the drug. One point that I would like to make, and John has heard it so many times that I think he is almost sick of it, is I don't subscribe to universal prophylaxis as such. So this is something that needs to be seen going forward. But clearly, there are some advantages of using this drug in special situations.
Okay. Thank you, Dr. Husain. And please, could you repeat the role of routine bronchoscopy in what is the protocol of your hospital? I think this is a very important issue because some places in the world they don't have like a regular scheme for bronchoscopy.
Sure, every centers differ a bit, but like our protocol is routine surveillance bronchoscopy, 4 weeks, 3 months, 6 months, 9 months, 12 months, and then 18 months and 24 months. But bronchoscopy is like getting a blood test done in lung transplant recipients. So if they have any symptoms, they should undergo a bronchoscopy as soon as possible. And the importance of surveillance bronchoscopy was highlighted by the case. Patient was asymptomatic with no findings in this, but had a bronchial anastomotic infection as well as the tracheobronchitis, and bronchial anastomotic infections in the early part of the transplant is disastrous because it can result in the dehiscence of the anastomosis and can make the management of these patients very difficult. So, but people do debate whether they need to do surveillance bronchoscopy. I wish there was an easier way to surveil these patients. Like one of the things that we have worked on is exhale breath condensate. Unfortunately, it didn't pan out, but we need to have a non-invasive method of detecting.
Thank you. Thank you so much. Please, Emily, I would like to know if in a situation that we use an organ from a colonized or infected donor, what should we do if there is an isolation of Candida auris? We just start
Yeah,
drugs?
I I don't think we know. We don't really have the data to guide us. I mean, there were those few case reports of it happening kind of in the literature where it was first, blood cultures identified in the recipient, and it was after the fact identified in the donor as a donor-derived infection. We don't really know what to do. There's a lot of need for data because are we taking organs from recipients who are colonized with C. auris without knowing it? Maybe, because not every center screens. And so I think we need to kind of see where the data points us. We don't really know, but I think it's reasonable to use an echinocandin in those situations, particularly if you know that the donor's infected, then absolutely.
Yeah.
If the donor's colonized, I think the data is a little bit less clear.
Yeah. One issue is that not all of the programs usually do like a screening of the donor, or even they have a look like in the preservation, liquid, and etc. And we know by literature that that can happen. Thank you very much. Please, Dr. Slavin, could you explain us what is the routine of the indication for surgery if there is in mucormycosis?
Yeah, thanks, Vanessa. I think sometimes it really depends on the patient's phase of their disease and whether it's thought that they would be able to tolerate surgery. Certainly, if it's a single nodule, we're very happy to proceed to surgery. It's a little bit more tricky where multiple lobes are involved or whether you have a very large lesion. The other indication, of course, is if surgery is needed because of hemoptysis or life-threatening bleeding. And then, of course, there's no question that the patient urgently needs to have surgery to stop that life-threatening bleeding. And it's terrible when you see mucorales eroding a large artery. This is a disaster. But I think in the other settings where we're dealing with pulmonary infections in patients who are neutropenic or going through treatment for graft versus host disease, we always have to weigh up the risk of surgery versus the risk of treating with medical treatment and potentially even reconsidering surgery later down the track. So it's not something you only think about once. You often will think about it initially. If it can't be done, reassess it in another couple of weeks and see if it's now feasible to do it, if the lesions have shrunk or improved. So I guess that's in general, my approach.
And after surgery, would you maintain like the antifungal drug?
Definitely. I think in these patients, although we stage and we do scans and we even do PET scans often when we've diagnosed mucorales to try and look for lesions elsewhere where we don't suspect them, I think we're never completely certain that this patient doesn't have residual fungal infection even after surgery. So yes, we would routinely continue antifungals.
So I guess we have to finish our section. Thank you everyone to be here today. Dr. Baddley had to leave to another meeting, unfortunately. And I want to make sure that everyone is aware of the upcoming TTS Congress in Sydney. There will be a pre-Congress symposium hosted by the TID section, and it's you can have a look at the TTS website for this. That will happen September 20th, and we hope to see you there. The recording of today's webinar will be made available through TTS. We encourage you to visit the website for information, and thank you again for joining us. And I wish you all a very special and wonderful day. Thank you.
Thank you. Thank you.
Thank you.